Addressing a very important topic, and it's been made easy by my previous speakers. And I have a very formidable opponent. So let me first of all thank Banshi sir and everyone for starting this group and then organize a full and wonderful conference. So my opinion that I'm going to express now is on the burden of diabetes distress and whether it is undervalued in clinical practice. Well, yes, I definitely believe so. So we've heard diabetes distress is an array and a combination of stress, anxiety, fear, frustration, depression, etc. And we know that it is common. In fact, one in four patients with type 1 diabetes and do have diabetic distress, with the overall prevalence of diabetic distress globally amongst type 2 diabetes is about 36%. And India is not lagging behind. In fact, this study estimated the prevalence of diabetic distress to be at 33% amongst patients with type 2 diabetes in India. If you go to see on an average, about 50% of the patients will have diabetes distress at some point of time during their life. And therefore, we need to address this because diabetes distress is most commonly associated with either an emotional burden or second is regimen related burden. So, this regimen related stress is what we all can actually handle. Why is diabetic distress so common in India? Well, we have the highest number of diabetic patients, so we have a high diabetic distress as well. But we are unique in the form that we are a little culturally and socially different as well. So, are we undervaluing diabetic distress? Let's have a look. When a patient comes into the clinic, what you ask them is, "Pair dard kar raha hai? Are you having any infections? Did you get hurt anywhere? Any other problems?" We focus on the physical symptoms, not on the mental health. We've moved from a conceptual therapy to an audiovisual therapy where you just talk and you just see, and whatever you see, you treat. So there is lack of awareness about diabetic distress not only amongst the general population but also amongst us doctors. Of course, there are financial and healthcare constraints as well because patients don't want to have lifelong treatment, don't want to spend a lot on psychologists and psychiatrists, in addition to spending on diabetes, blood pressure, etc. There is a cultural and social stigma around mental health, which we'll talk about in some time. And yes, there are gender differences as well. Now, the problem with diabetes distress is it manifests in a very vague symptoms. So, fatigue, loss of interest, psychosomatic symptoms, etc., which are often seen in other conditions like uncontrolled diabetes per se, or neuropathy, or menopause, aging, nutritional deficiency. So, all of these will give rise to the same symptoms, and it is up to us to actually dig out whether the patient has diabetic distress as well. And hence, these are often underrated, ignored, and underreported by the caregivers of the patients with diabetes, and often fail to be detected by us doctors. So, patients who are having severe diabetic distress, as are earlier speakers said, they are often misdiagnosed to have depression, and we do not know how to differentiate between it. So, valuing or undervaluing of diabetic distress depends upon three parameters. First, let's take the social stigma. So, DD unfortunately is associated with a very negative aura. Ignoring the signs and symptoms, failure to recognize the changes in behavior is extremely common. In fact, there is a stigma associated with mental health illness per se. And this is a study from Kerala, which has shown that rather than self stigma, which is identified in USA, Indian patients see it more like a societal problem, as Dr. Firdaus said, more to do with pregnancy and marriages. And therefore, they downplay the symptoms, they ignore the emotional struggles because they don't want to seem less healthy. Now, in this particular aspect, the male gender takes precedence because they feel that this will be seen as a flaw or a weakness in them, especially if they are suffering from sexual dysfunction as well. So, a lot of marriage as well as relationship dysfunctionalities also occur, adding to the stress burden of these patients. Of course, there is financial stress. You, me, I, everyone is suffering from the same. And most importantly, we also fail to notice the diabetic distress, not just in the patient, but that can also occur in the caregiver. So, we are focusing on the patient and forgetting about the caregiver, which should not be done. Let's talk about our role for a minute. The doctor's chamber is a sanctum. There is overemphasis on glycemic control, if there is stressing on complications in a negative manner, तुम्हारा कभी शुगर कंट्रोल में नहीं है, तुम्हारा किडनी तो गया, छोड़ दो. I have heard people say this. So this gives a negative aura. Remember, the attitude of the HCP actually transfers onto the patients and his attitude towards the disease. So what we do actually translates onto our patients. Pointing out the inadequacies of patients' efforts or blaming the patients for his actions does not go a long way. There are sometimes doctors who will always say that I am the doctor, yeah, you are the doctor, listen to me first. So, this failure to listen actually closes the communication between the patient and the doctor. Second, there is also the discussion is in presence of a relative or even the next patient in waiting, which actually sort of discourages the patient from talking about mental health issues. We are a God fearing country, we are a insulin fearing country as well. And many use insulin as a threat, a hanging sword for control of sugars, which again adds to the diabetic distress. We are also not trained. Psychological care has always been underrated, right from medical college till date of clinical practice. It's always been underrated. So we actually are underconfident to diagnose, treat, and refer the patients. And if we refer, there is no guarantee that the patient will actually follow up with the psychiatrist or the psychologist. So most of the times, the doctors will just prescribe some antidepressants, anxiety drugs, and put them on their way. So that again is a lacune. Third most important aspect is limited consultation time. The Dawn 2 study, which was conducted across 17 countries, showed that of 8,500 patients, 45% showed that they had diabetes distress, but only 24% were asked about them by the healthcare team. So this shows what is the lacune here. ADA recommends annual screening for diabetes distress, has given a beautiful 7A's model. Similarly, NICE guidelines also endorses screening for diabetes distress, and we have wonderful tools for detection as well. Do we have the time? It was always mentioned that I give the DDS chart outside in the waiting area, but 90% of the patients will pick what they feel will be adequate, not what they really feel. Then valuing of the chart takes time. Then going back to the patient and convincing them that they have a distress takes time. And then finally, patient accepting and getting treated for it is a very, very different story. So it is easy to screen, but it is very difficult to convince a patient that you have this kind of a problem. There is an inadequacy in Indian OPDs. This particular study, which was done in a tertiary care center in Uttarakhand, has shown that the patient's average waiting time is 50 minutes in the waiting room, while the mean consultation time with the doctor is less than 10 minutes. So you see that there is a big gap between what we are giving to the patients and what the patient is actually undergoing. Of course, there is lack of integration of healthcare facilities as well because there is no connection, there is no talk amongst the super specialist doctors. So we have an eminent psychiatrist sitting in the podium, but how much will I talk about one particular patient with to him is a very different story. So because of the load, patient load, because of the inadequacies of communication, the patient will suffer at the end of the story. So remember, mental health will up the risk of diabetes distress, and diabetes distress ups the risk of mental illnesses. But there are a lot of barriers to diagnosing, treatment of diabetes distress and mental health illness. Probably because we have limited health facilities, we have limited economic facilities, and therefore it is a little bit of a troublesome picture. Dr. Firdos has already shown you this slide. There is an intimate relationship between diabetes and diabetes distress. But we must remember, although greater diabetes distress tends to be associated with higher A1C, optimal A1C is not necessarily an indicator of diabetes distress. And this is something that we generally forget. So, to conclude, patient centric diabetic management requires addressing the psychological aspects of patients with diabetes as well. Where current health system focuses mainly on the physical symptoms, we have to incorporate mental health for a holistic diabetes care. Uncontrolled diabetes and its complications will lead to greater diabetes distress and vice versa. And by integrating mental health into diabetes care, implementing regular screening, creating awareness not only amongst the general population but also amongst us doctors can significantly improve the life of millions of patients. Aim for equal importance to physical and mental health. So, coming back to the question, are we undervaluing diabetics distress? As of today, yes, but fingers crossed for a wonderful tomorrow. Thank you.